Welcome, everyone, to the final event of MEDiversity Week 2023. I'm Dr. Amanda Bakian, Associate Professor of Psychiatry at the Huntsman Mental Health Institute and co-director of Women in Health, Medicine, and Science. I'm joined today by my fellow co-director and co-moderator, Dr. Holly Sharp, and UHEDI Administrative Manager and co-moderator, Jen Wilson. MEDiversity Week is in its fourth year, and this year's focus has been care for all ages, emphasizing anti-ageism in healthcare and recognizing the University of Utah Health's recent designation as an age-friendly health system. With the Care for All Ages theme, we draw attention to the importance of designing and delivering care that meets the needs of every person, regardless of age. We're excited to have you join us in our fantastic group of panelists to talk today about menopause. Before we introduce our panel, we would like to start with the University of Utah's land acknowledgement. We acknowledge that this land, which is named for the Ute tribe, is the traditional and ancestral home of the Shoshone, Paiute, Goshute, and Ute tribes. The University of Utah recognizes and respects the enduring relationship that exists between many Indigenous peoples and their traditional homelands. We respect the sovereign relationship between tribes, states, and the federal government, and we affirm the University of Utah's commitment to a partnership with Native nations and urban Indian communities through research, education, and community outreach activities. So we have three fantastic panelists today, and I'm going to first introduce you to Dr. Karen Gunning. Dr. Gunning received her Doctor of Pharmacy from the University of Utah and completed a postgraduate residency in family medicine and primary care at the University of Washington. She's currently a professor of pharmacotherapy and associate dean of community engagement at the University of Utah College of Pharmacy. She's also an adjunct professor of family and preventive medicine, a clinical pharmacist for the University of Utah Family Medicine Residency Program at the Sugar House Clinic, where she participates as part of an interdisciplinary team in providing exceptional care to patients, and one of the ombudsmen for University of Utah Health. She's taught sex and gender health pharmacotherapy and pharmacology for the pharmacy and medical students for many years, and has professional interests in shared decision-making for medication therapy in these areas.
And our second panelist today, Jamuna Jones, LCSW. Jamuna is a therapist and well-being specialist in the Resiliency Center with University of Utah Health, where she provides mental health treatment and wellness support to faculty and staff. Prior to her role in the Resiliency Center, she was an assistant clinical professor and director of field education in the College of Social Work. Her clinical interests include trauma-informed care, healthy aging, nutritional psychology, and cultural humility in practice. And our third panelist, Dr. Katie Ward. Katie has been working as a women's health nurse practitioner for over 20 years. She is a Menopause Society certified provider. And in addition to menopause, Katie specializes in general women's health care across the lifespan, family planning, sexual dysfunction, and abnormal pap management. She teaches in the Midwifery and Women's Health Graduate Program at the University of Utah College of Nursing. She is also a PhD candidate in anthropology, where she studies hormonally mediated behavior across the menstrual cycle. Welcome, and thanks to the three of you for joining us today. We're excited for your insight and your expertise on this topic. And I'm going to first turn the time over to Dr. Ward to get us started with some slides.
Great, thank you so much. I'm really excited to be here. Can you see my slides okay? Perfect. And I'm also going to set a timer just so that I don't go to, maybe I'm going to set a timer. Let me know if I start to go over. I get really excited about this topic, and it's the place where I work, and I think there's a lot happening in menopause at the moment. Menopause seems like it's really having a moment in the national zeitgeist. For better or for worse. So I'm excited to get a chance to talk to you a little bit about it. And what I wanted to start with was a little bit about why we have menopause and what's going on. So I'm going to start with a basket of eggs. If you are born with two X chromosomes, and everything assembles according to instructions. As a fetus, you grow 2 ovaries that are just chock full of these little primordial follicles. And they're pretty active in fetal life, making estrogen that sort of causes the assemblage of the female phenotype. And those are all the eggs you're going to have for your lifetime. And although they're very active in fetal life, they're also undergoing atresia and sort of disappearing across the lifetime. So they stay kind of quiet through your childhood, and around age 10 to 12, they start to become active and begin the process of ovulating. And they ovulate on a fairly regular basis throughout the reproductive years. But around age 51, people are just out of eggs. So that it is the follicle, the developing follicle in the egg, that's making the reproductive hormones. And it always says this in every textbook, but somehow that's one of those V8 moments for me, that hormones are not being made by the ovary as a gland. They're being made each month by a separate egg as that egg develops. And I think that that's important in understanding what's happening during menopause. Now, this is a schematic that I think is familiar to lots of people if you've taken any kind of a biology class, in terms of explaining how the menstrual cycle works. So we look at menstruation. We always kind of look at the first day of your menstrual period as that first day of bleeding. And then there's the follicular phase as the follicle's developing. And then that triggers the ovulation. And then after you ovulate, that same place in the follicle that was making estrogen in the first half now makes both estrogen and progesterone. And we call that the luteal phase. And if there's no pregnancy, the drop in progesterone at the end of the luteal phase triggers a period to happen. And again, just back to the point that these hormones are being made by the egg. So this is a little bit of a complicated slide, but I think it conveys a lot of important information. So I think the first thing to look at here is this line, and hopefully you can see my pointer, at about age 51. This is the average age when women experience their final menstrual period. So average age means that half of women have stopped having their periods by 51, and half are, still have a few periods left to go. Once you've been 12 months since your final menstrual period, then we can say a woman is truly menopausal. But until you've gone 12 months without a period, it's possible that there's one last ovulation coming that is triggered by this rise in FSH. So the pituitary hormone FSH is kind of yelling louder and louder at the ovary to try and make one more egg. And every once in a while it does, and that resets the clock, and we go back to waiting for 12 more months for the last period. But that process for most women, I didn't mean to advance my slide yet. For most women, the few years leading up to the final menstrual period and the couple years afterwards can be pretty rocky. Those final eggs sometimes ovulate and sometimes do not. Usually the first thing a woman sees as she's starting to enter this perimenopause transition is that her cycles get a little closer together. They may be heavier. They may be lighter. She may skip a few. She may have a few that are normal. So there's lots of erratic changes going on from month to month as you kind of are using those oldest and last eggs in the basket. So that's a period of time when people often have very frustrating symptoms. That is, some months they may have significant hot flashes because that egg is not producing a lot of estrogen. But then the next month, things are a little bit more normal. They may have a heavy period. They may have a period of time where they're skipping some cycles, and then one shows up out of the blue. It's the hot flashes, though, that really cause people probably the most difficulty. So those hot flashes affect your sleep. Some people don't even wake up when they're having one, but their sleep is really disordered. Not getting restorative sleep, we know, leads to a lot of other issues. It affects how you process information and your ability to think clearly, and something that we call brain fog. It can affect your mood. It can affect your weight. So not getting good sleep has a lot of downstream effects. So if we can help women with those hot flashes in the day and in the night, that can help relieve a lot of those symptoms of the perimenopause. The trick is, there's this little window of time when you haven't had your final menstrual period yet and you're still ovulating erratically, when menopausal hormone therapy, sort of the traditional doses, aren't adequate to turn that whole pituitary ovarian communication off. And so in those last reproductive years, using some kind of contraceptive method is really important. One, women can still get pregnant. And two, if you want to really, kind of fix the symptoms, you really need contraceptive doses of hormones or some combination of an IUD and a vasectomy, and then some hormone therapy to manage the symptoms. But pregnancy prevention is still important in those last years leading up to the last period. Now, some women, everybody's different with this. So menopause is very individual. Some women have a period every 28 days, like clockwork, and then one day just don't have a period, and they're not troubled by a lot of hot flashes. And they wake up in 12 months and say, oh, well, there was that last period, and it must have happened and things were fine, and I'm not feeling bad at all. And so menopause is not a disease. It's not something that everybody has to treat. And not everybody benefits from postmenopausal hormones. As you go longer and longer in this low estrogen, low progesterone state, though, there are some long-term changes that start to happen. So as we talked about, in that window right around the menopause is when people are having these kind of fluctuating systems and really the hot flashes and the more wild ride. But as you get further and further past that last menstrual period and you have a chronic low estrogen state, then people really begin to suffer with more what we call genitourinary syndrome of menopause, where the tissue of the vulva, vagina, and urethra get thin. That can lead to bladder infections, painful intercourse, discomfort around the vagina. And then the other thing that we worry about is osteoporosis. So as women get past the peak estrogen years, estrogen's involved with bone formation, and the risk for osteoporosis increases. And both of those things seem to get worse with age. So this is just a collection of some of the symptoms women experience throughout menopause: the hot flashes and night sweats, the vaginal dryness and pain with intercourse, changes in their menstrual flow, changes in their sexual function, insomnia, leaking urine, difficulty with concentration or memory loss, mood swings, headaches, decrease in energy, sometimes bone pain. So there are lots of things that often are improved with some postmenopausal hormone therapy. So I'm going to share with you my approach to managing the menopause, just as in sort of 10,000-foot view. And Dr. Gunning is going to talk a little in more detail about some of the medications. But so when someone comes to me and they're having these experiences of perimenopause or postmenopausal symptoms, then we're going to look at what those symptoms are. What are their risks? And that's the thing about postmenopausal hormone therapy, is it's always a risk-benefit trade-off. So I'm looking carefully at their risk for cardiovascular disease, for breast cancer, for venous thrombotic events, and their long-term risk for osteoporosis. So using estrogen in the early menopause can be a way to postpone or prevent osteoporosis down the road. So we're weighing all of those things and then looking at what are going to be the best treatments. So we do have, for people for whom menopausal hormone therapy is not appropriate, we do have some alternatives, including some of the antidepressants in the SSRI or SNRI category. Some people do well with progesterone only without the estrogen. Gabapentin, which we use for some pain states, can be helpful with hot flashes. There's an old blood pressure medication called clonidine that can be helpful. Sometimes just lifestyle changes, dressing in more layers and changing the sheet configuration and getting a fan for your bedroom can be helpful. And then we do have a brand new class of drugs that are these NK3 receptor inhibitors. They've just hit the market. They work directly on the hypothalamus to reduce hot flashes. They don't have some of the other hormonal benefits, but they can help with the hot flashes. And that's pretty exciting for people like people with breast cancer who maybe really should not take menopausal hormone therapy. If people's symptoms are confined just to the urogenital symptoms, then we can treat most everybody with a little bit of local estrogen applied topically to the skin, or there's an estrogen precursor called DHEA, sometimes just lubricants and moisturizers. And then there is a selective estrogen receptor modulator, OSFEM, that works just on that skin and kind of avoids stimulating the breast tissue. That's more specifically used for people who have breast cancer or at high breast cancer risk. But really what we're going to probably focus on next is going to be the people who are candidates for menopausal hormone therapy. And currently the recommendation is that if you're less than age 60 and or within 10 years of your final menstrual period, and you don't have any of the contraindications to estrogen, so considering all those things we talked about, breast cancer, risk for blood clots, risk for heart disease, that you may benefit from an estrogen, and if you have a uterus, an estrogen and progesterone combination. I'd say in general, for women under 60 who are otherwise healthy, the benefits almost always outweigh the risks, especially with a transdermal estrogen. So if you're suffering from these symptoms, I think it's definitely worth a visit to your healthcare provider to talk about are hormones a reasonable therapy for you. I think the thing that frustrates me a lot in my practice is that there's very much a industry out there that are not presenting the risks and benefits, I don't think, honestly. They're charging women a lot of money out of pocket for measurements that they don't need, and hormone therapy that's not as carefully tested as the things that we're providing in my clinic. So I think Karen's going to get into talking a bit more about the hormones. So I want to pass it off to Dr. Gunning, and then we'll come back for questions about this in a few minutes.
Wonderful. Thank you, Dr. Ward. Yeah, we'll turn over to Dr. Gunning now. Thanks for setting the foundation in terms of physiological and hormonal changes and symptoms and approaches to treatment. Just a reminder that if there are questions that come up in the audience, please use the Q&A to put your questions there, and we'll hopefully have time to circle back to them later.
Well, wonderful. Thank you, Dr. Ward, for setting me up so nicely and for being such a great long-term colleague here at the University of Utah. I think, and I'm hopeful everybody can see my slides. It's always the mystery of Zoom. Okay. So, I have been teaching this since 1998, and I think that the only thing that is constant is complete change, absolute change. Everyone should be on estrogen. No one should be on estrogen. Everyone maybe kind of is a candidate for estrogen. So we've seen a lot of change with this, and I think that makes it really hard. Whenever we have changes in professional guidelines and evidence, it just makes it really hard for both providers and patients to be able to figure out what is the right thing to do. So one of the areas that I really love is a aspect of medical decision-making and patient medical decision-making that's called shared decision-making. And what this is really considering that the patient is the expert on what matters to them. And they're the expert on the symptoms that they're having and the concerns that they have. And our healthcare providers, including physicians, nurse practitioners, PAs, pharmacists, should be the experts on what are the latest information about the risks and benefits of different treatments. So shared decision-making means that these two things are coming together and that there is an ongoing discussion about what is right for the individual, not a blanket yes, no, which I think sort of happened in the past 10 or 15 years, but really what is the discussion about this for the individual patient that is in front of us? So one of the things that to begin the state of shared decision-making, I think it's really important to think about, as Dr. Ward presented, what are the symptoms that I'm having that estrogen options will help? And I think this is where there is a lot of stress in our systems. We've just gone through a pandemic. And there is a desire to have a magic pill that fixes everything. And of course, we all know that's not the case. So I think it's really important to identify those symptoms that estrogen options will really help with. And Dr. Ward talked about these, but we're talking about things like hot flashes and night sweats that really impact sleep. Vaginal dryness, I think, is not talked about enough. Vaginal symptoms where that can really impact overall functioning. So the key question or the key assessment for both patients and providers is, are these symptoms affecting quality of life? And for some people, the answer is absolutely yes. And for some people, the answer is no. So are these affecting the quality of life, daytime functioning, and sleep? And I would agree, and I suspect Jamuna is also going to agree that sleep is the magic. If there's a magic bullet, it is sleep. So the key question from this is, how will estrogen benefit me? And then you have one side of the balance to say, what might be the potential benefits? So then we have to think about risks. And I think this is where we've kind of gone off kilter and we're swinging back to be more centered in terms of how we think about making decisions, both from a patient and a provider standpoint. So there are risks, and I will tell you, there are risks of everything. There are risks of vitamin D. There are risks of vitamin C. You know, everything that has a benefit is also going to have a risk. So if we think about the specific risks of estrogen, one thing that I think is very important is, if a patient has a uterus, and they are seeking to take estrogen for menopausal, perimenopausal symptoms, they also need to take progesterone, because we know that estrogen causes endometrial cancer. And when you take progestin with that estrogen, you negate that effect. So you do not have a risk. So if a person has a uterus, they need to be on both estrogen and progestin. If the patient has had a hysterectomy and doesn't have a uterus, there isn't an endometrium, and they don't need to take progesterone. A patient with a personal history of breast cancer should really discuss estrogen therapy with their oncologist. Now, there are situations in which vaginal estrogen are appropriate in these patients, but this needs to be a discussion with the person taking care of their cancer. End-stage liver disease, estrogen generally should be avoided. Heart attack, stroke, mini strokes or TIAs, a patient who's had those or is at high risk for them, estrogen may impact the risk for those. And that's a little bit more complicated conversation than that, but this is kind of what has driven a lot of our sway away from estrogen. But really, we just need to look at an individual patient perspective and see what their individual risks are. One of the things that actually comes up quite a bit in my work is, if a patient has vaginal bleeding, if they're menopausal and maybe they haven't had a period for a couple years, and all of a sudden they start having vaginal bleeding, that needs to be looked at. So those patients should not be started on estrogen until that is evaluated. Also, just as an added information point, someone who has been on estrogen for menopausal symptom treatment and suddenly starts having vaginal bleeding, that needs to be investigated as well. And then blood clots. If you've had a blood clot and you're not currently being treated for it, this is something that should be discussed with a healthcare provider, because estrogen does increase the risk of blood clots. And this is not all inclusive, but this is the information that a provider would seek to be able to assess what are the risks of therapy. And as Dr. Ward pointed out, and this is just another schematic way to look at what she presented, this is, a compilation of potential benefits, potential risks, and then looking at whether in that individual there should be hormone started, or if this is if the benefits are greater than the risks. So I love this little drawing. I can't remember where I got it. I think it's probably 25 years old. But this is really about, what are the specific reasons? What are the potential benefits? What are the potential risks? And this is not a solitary conversation. This is not make a decision at 51 and take hormones until you're 90. That was 1995. This is not how we do things now. So having this conversation every year as a patient's individual risks and benefits may change is really important, because it is not a medication to be taken for the rest of your life. It's something to be taken, symptom treatment, and then looking at, should we decrease the dose? Do we still need this? What are we still treating at that time? Okay, so if you and your provider decide that estrogen is for you, there's questions about what forms of estrogen. And I will tell you that in the past 15 years, there has been an explosion of the types of estrogen that are available for women to take. Most of them are very expensive. And so I tend to focus more on 3 different types of medications. As Dr. Ward said, vaginal symptoms only, use vaginal estrogen. And there are creams, there are vaginal tablets, there is a vaginal ring. And with this kind of therapy, you're treating locally. So you're applying a cream to the vagina. The vaginal tablets have an applicator to insert the tablet in the vagina. And that is not providing a systemic effect. So a lot of the risks that we've talked about don't apply necessarily in that condition. So there's not a need for progestin if the patient utilizes the therapy in an appropriate way. If you have systemic symptoms, hot flashes, driving you crazy all night long, then you need a systemic estrogen. And the most commonly used and reasonably priced products are the pills and the patches. There's some theoretical advantages for the patches, plus it's also a little bit easier. So that tends to be a really common mechanism. Now, we can talk more about this in questions, but one of the things I wanted to bring up, both Dr. Ward and I wanted to bring up, is you may have heard a lot about bioidentical hormones. Bioidentical hormones are chemical entities. They are not better, they are not safer, they are not more personalized, they are not natural. But bioidentical means same hormone as in the human body. So estradiol and progesterone are our endogenous, what is in our body as women, and that is what bioidentical refers to. And there are bioidentical commercially available products out there. So on the other hand, what if you and your provider decide estrogen is not right for you? If you identify a dietary supplement that says it treats hot flashes, I guarantee you that it'll act in the same way as estrogen. And so those may be a similar safety concern if you have a reason you can't or don't want to take estrogen. So talk with your pharmacist about that. Non-drug things can be really helpful. We laugh when we talk about fans. I have had numerous pharmacy students bring their menopause fans to class and sit there with the fan on them. If that works, and that's just fine. There are several drugs that are typically used as antidepressants that can be used. There is a good number of over-the-counter vaginal lubricants and that can be used, that can be very helpful, and they're more accessible because of their lower cost. And then the new drug, Fezolinet, that is available, it is a very high cost drug. It's $550 to $650 a month, but it's a very important option, especially for those women who may have significant hot flashes caused by breast cancer treatments, but can't take hormones. So I don't think this is like the magical answer. And I have some thoughts that the reason we're hearing a lot about menopause right now is because we have a new drug on the market that's different. But I think it is an important option to think about. So I wanted to give people a few resources because I think that's a huge issue as well. And we can talk about that more. But, you know, if you go on a website and they're selling something, that's probably not the website to be on. So I've given some resources, the North American Menopause Society, the American College of Obstetrics and Gynecology, and some government resources that are available out there for high quality information where they're not trying to sell you something. So with that, I am going to stop sharing and we'll pass it on to Jamuna.
Yeah, thank you, Dr. Gunning, for presenting a really sort of sensible approach to when you're feeling some symptoms related to perimenopause and menopause. Very important and excellent information. So yes, now we'll turn over to Jamuna and her presentation. Thank you. Right.
All right. Thank you so much for having me today. My name is Jamuna Jones, and I'm delighted to be part of this very, very important conversation. And I'm going to talk about mental health and menopause. So first, let's look at the research. The research tells us that perimenopause was associated with an increased risk of depression and anxiety in women, even without a history of depression or anxiety disorder. Psychological symptoms were significantly elevated in perimenopausal women compared to matched premenopausal women. And during the menopausal transition, symptoms of anxiety and depression are very, very common. We find that menopause increases our vulnerability to depression and anxiety, and it's believed it's because of the estrogen fluctuations affecting our neurotransmitters serotonin and GABA. So there are many risk and protective factors that'll determine whether or not we'll have those mental health symptoms. Some major risk factors include the vasomotor symptoms. And so when I say that, I'm talking about the insomnia, the hot flashes, that's a risk factor. If we have a history of major depressive disorder, a history of anxiety, just general stressful life events, and then also low financial or educational status. Some minor risk factors to consider is lack of social support. Really, really important that we are connecting with each other and have that support. Another one is being single or divorced. I found this one to be very, very interesting. Negative perception of aging, how we actually perceive aging, if we're looking at, really trying to fight against it, that actually impacts how we kind of progress through these stages and our mental health symptoms. Also, if we've had a history of premenstrual syndrome and also a history of premenstrual dysphoric disorder. And if you haven't heard of premenstrual dysphoric disorder, it's called PMDD. Essentially what that is, it's a severe form of PMS where the symptoms are very, very severe and really cause disruption in your life. And then we've got a lot of protective factors that we need to consider. Again, with that social support, being able to reach out and have support and talking to other people. And then positive affirmations, being kind to ourselves, reminding us of the good things that are going on. Like the previous doctors had spoken about, the menopausal hormone therapy, psychotherapy. I'm biased because I'm a therapist, but psychotherapy can be very, very helpful of just being able to get a different perspective, being able to talk about it and perhaps learn some new coping skills. Engaging in a healthy lifestyle, I'll talk about that in a little bit, and definitely exercise. So these are some symptoms that can show up in perimenopause or menopause. Mood swings are common, irritability, anger, like I mentioned, depression and anxiety, sleep disturbance, and that means either having difficulty falling asleep or staying asleep, having that forgetfulness, poor concentration. The brain fog is very, very common. We can also, our confidence and our self-esteem can really take a hit during these times in our life. And in very, very rare cases, there is a diagnosis called menopause-associated psychosis. And that is essentially, it's very, very rare, but the symptoms would include some hallucinations and some delusions. And that can absolutely be treated by talking to your provider. So some challenges. Some women may not know that the symptoms that they're experiencing are related to menopause, or that there are treatment options that can help alleviate discomfort. So some people just suffer in silence because they're just not aware. And those experiencing menopausal symptoms may be embarrassed. They may feel some shame about drawing attention to their symptoms, and that may prohibit them from asking for that much needed support. And when menopause occurs, it's during a time when women are facing multiple sources of stress, including, caring for children. Some of us are in that sandwich generation where we're caring for our kids plus our aging parents. And then also navigating just the adjustments of life, these life changes. So an example of that would be, adjusting to having an empty nest. All of these can make all of those situations more difficult. So some treatment recommendations. Talk to your provider if you're having any of these symptoms that are really disrupting your life. There's lots of treatment options, so please don't suffer in silence. Go talk to your provider, and they'll be able to help you with the different options. Like I mentioned, psychotherapy, antidepressants may be indicated. And something to think about with the antidepressants, first of all, the research shows that a combination of psychotherapy and antidepressants are the most effective. And when antidepressants are indicated for perimenopause or menopause, it doesn't mean that you'll have to be on these medications for the rest of your life. Often after menopause the cycle has been completed, a lot of times women are able to get off those antidepressants. Exercise. This is really a silver bullet for everything. This addresses our stress. And it really can help our mood. Limit the caffeine. Caffeine can really cause our body to feel more stress, and it actually can exacerbate our anxiety. So pay attention to how much caffeine you're drinking and seeing if reducing it or even eliminating it out of your diet. See if that makes a difference in your stress level and your anxiety. Definitely pay attention to nutrition. This is something I'm very passionate about. Eating a clean diet of like whole foods, lots of vegetables, moving away from processed food and sugar can really have a huge impact on how we feel. And practice self-compassion. This is another thing I could talk about all day. Pay attention to how you talk to yourself. A lot of times we're very critical. And if we're suffering, if we're having a lot of problems and suffering, we may tend to even beat ourselves up even more for suffering. So take a step back and really look at how you're talking to yourself and start having some grace for yourself and talk to yourself like you would somebody that you love. Practice stress reduction. This can be very helpful during these very stressful times in life. I'm a big fan of yoga. Yoga is not about being flexible. That's actually not what it's about. Yoga is about really, getting in touch with yourself, getting connected with your breath and your body. And there's been a ton of research on yoga, and it can really help with stress reduction. There's tons of videos on YouTube, so you can just pull out your mat and just click on a YouTube video and start practicing. Mindfulness and meditation have also been shown to really help with stress reduction. When I say mindfulness, I'm talking about just being present, being in the present moment, acknowledging what are you thinking about, how are you feeling, and getting in touch with how your body is feeling. And meditation is actually a type of mindfulness where you can have like this guided meditation. You put your headphones in and just listen to a guided meditation. And when you're meditating, just know that it's normal that your mind is going to wander a million times during that. And that doesn't mean you're doing it wrong. That just means that you're a normal human being. But meditation has a lot of research and a lot of benefits. And it's really easy. It's really easy to try. So some apps you can try. Headspace is a really great one that I love. And actually, there's a show on Netflix called Headspace, a guide to meditation. And so it'll actually the show tells you why meditation is so helpful. And it has meditations built in. So I recommend checking that out. Some other apps I really like would be the Calm app, Insight Timer, and Better Sleep. Journaling is a really great way to reduce stress. I mean, just getting everything out of your head on paper actually helps our brain process the problems that we're experiencing. So it's a way to just get it out. Getting a massage is really helpful, getting that stress out of our body, playing music, and then, of course, like I mentioned before, making sure that we are getting social support. We just simply don't heal in isolation. So that piece is very important. Some sleep tips. Perimenopause and menopause can be very disruptive to our sleep. So sometimes we need to really train our body how to have that effective sleep. So make time for it, meaning schedule it out, just like we schedule out our work day, making sure that we're protecting that time for our sleep and not letting anything get in the way. And create the best environment for comfortable sleep. So make sure your bedroom's quiet and cool. Put the fan in there for the hot flashes. Put in some blackout curtains. Everything we can do to make it comfortable. And be consistent. That is key here. So sometimes, again, we have to teach our bodies to kind of wind down. So with that consistency, our body's going to get in that routine and start winding down at a certain hour. Try to ditch the screens. We love our screens, right? But an hour before bed, I'd recommend not watching TV, not scrolling through our phones. First of all, I mean, if we're like reading the news before bed, that's going to be, stressful. So, an hour before we get to bed, engage in some really soothing activities rather than looking at screens. Read a book, have a cup of tea, just to help yourself wind down a little bit. If you are going to look at screens, make sure you invest in some blue light glasses. The blue light glasses help filter out the blue light so it's not affecting our melatonin. Limit the caffeine and alcohol. Caffeine has a long half-life and can definitely disrupt our sleep as alcohol does as well. If we are engaging in exercise on a regular basis, that really helps our body regulate and get back into that good rhythm of being able to fall asleep. And then, like I mentioned before, try a meditation before bed. Put in your headphones, click on one of those apps, and see if that can be helpful for you. And then lastly, what can you do to protect your mental health through menopause? Be aware. The big thing is just checking in to see how you are doing, right? Instead of avoiding and trying not to think about it, we want to do the opposite. Check in with yourself. How am I feeling? What am I thinking about? How's my body? Monitor your mood. Just jotting down a few notes every day to kind of, establish a baseline can really kind of help see what's going on with your mood. Make lifestyle changes. And when I talk about this, I'm really talking about the three big ones: sleep, nutrition, and exercise. Those three together make such a significant impact on our mental health. Reach out to others. Don't suffer in silence. Making sure that we're taking time making sure you're taking time for yourself. We love, as women, we love to give, right? But we need to make sure we're giving time to ourselves to fill our own cup up. And also know that it's temporary. I think that when we're in the midst of it, it can just seem very hopeless, and we can feel like, oh, this is going to feel terrible forever. But it is temporary. So just reminding yourself of that. Okay. And I'm going to stop right there.
Oh, Dr. Bakian, I think you're muted.
Apologies for that. Thank you, Jamuna, for that really important discussion about mental health, signs, what to look for, potential approaches to stress management, and the sleep tips. Really important. So we have about 18 minutes or so for some questions and discussion. And thank you to those who provided questions ahead of time when you registered. We're going to start first. We have a few that already came up based on the presentations this morning. So let's start the first question that came up, which is, until recently, I had not known that perimenopause and menopause can cause joint pain. Can you talk about why this happens and discuss approaches to treating joint pain, including non-hormonal treatment? So, and this is to the entire panel, so whoever would like to respond to that question.
I can jump in. It's an interesting thing. I think we sort of figured this out more by noticing that people who were taking menopausal hormone therapy were having less joint pain, but it does make a little bit of sense in that estrogen is linked with bone metabolism and also with collagen metabolism. So it seems like maybe people who are on the postmenopausal hormones, might benefit from like having a little bit more turnover in both bone and a little bit stronger collagen. I wouldn't necessarily start somebody on menopausal hormone therapy solely for joint pain. Like that does need a good thorough workup to make sure that there's not rheumatoid arthritis and the more likely thing, osteoarthritis. And there's some really good treatments for that as well. And Dr. Gunny, I might let you talk about those treatments a little bit more. But we have noticed that among women who take menopausal hormone therapy that they're noticing less joint pain.
Yeah, and I think as with joint pain that's caused by other things, the standard of treatment is things like acetaminophen or Tylenol, anti-inflammatories, if those are things that can be taken. But I think actually a lot of this may relate to some of the things that Jamuna talked about. So it's things like stretching, gentle exercising, maintaining flexibility, getting good sleep, dietary changes that can be really helpful as well. So there's several things that estrogens do seem to have a beneficial effect on, but as Dr. Ward said, we're not going to use them solely for that. So another one of those is osteoporosis. We don't use estrogen specifically just for the treatment of osteoporosis, but it's an added benefit when someone is on it. So.
It's okay. I'd like to ask a follow-up question to you, Dr. Gunning, about that statement about osteoporosis and estrogen, because I have heard some discussion elsewhere about the fact that, right, estrogen can be protective when it's taken during menopause. That's an added benefit, as you mentioned, prevention of osteoporosis. When in the last 20 years, we really did see a drop in estrogen use during perimenopause and menopause. How was the corresponding change in the risk of osteoporosis or even the prevalence of osteoporosis or incidence among women? Did we see an increase there?
That's a really hard thing to answer. I've never seen anything that specifically looks at, correlates of osteoporosis changing, because the other thing that was going on at the time is a massive increase in screening. So, when I first started teaching, I don't think I taught osteoporosis because we didn't have drugs to treat it. And so it's hard to tell what has an impact on that. I think it's a positive that there's a greater sense of, let's not shut the door on estrogen these days, because it is beneficial to help maintain bone mass. In that time, without estrogen, there's a precipitous drop in bone mass that occurs with menopause, and this can help stem that. But there's also a lot of other things that can help stem that as well, like adequate calcium intake, weight-bearing exercise, adequate vitamin D intake as well.
Thank you. That's helpful information to put that into context. Excellent. Okay, so let us go to our next Q&A question. Okay, that came based on the presentations. We have a question about the Mirena IUD and a use example of I'm 49 and I've had the Mirena IUD for the past 7 years. I've discussed with my provider getting another IUD to keep the benefits of progestin, e.g. no periods through the perimenopause period. Thoughts on this? And how would I know when I have reached menopause? Also, if I need HRT during this period, would that be estrogen only? And I know there's a number of women maybe where this is the scenario. So would love some thoughts on that from our panelists.
I would love to talk about that. And there's another question about IUDs as well. So maybe we can answer both of those or address both of these together. I think this is a really exciting way to manage the menopause. So I talk to women about this before they go through menopause, that this is a great time to consider getting an IUD for kind of controlling some of that erratic menstrual cycle changes that are happening in the perimenopause. One of the benefits of the IUD is you have much lighter or maybe even non-existent periods. And then if it turns out that you're having a lot of hot flashes and you're wanting to use some estrogen to manage the hot flashes, you're delivering the progestin locally in the uterus. So you're not getting a lot of systemic absorption of progesterone, but you're getting the progesterone right there where it's protecting the endometrium, as we talked about. So you get very good endometrial protection, and you can use estrogen in whatever other form is appropriate for you, oral or transdermal, at a dose that manages your hot flashes if you're experiencing those. People are asking questions about how do you know? So you might know you're in the menopause, or at least in that transition, because you begin having hot flashes, even though you're not having periods. And you might be one of those lucky people that doesn't have any hot flashes. And then, as you get to the end of the lifespan of your IUD, then we may do some testing, the FSH testing, to see if that hormone that your pituitary produces is high enough and sustained high enough that we can say, yep, you're definitely past the menopause, and all we need to do is take the IUD out now. But for the person who's 49, I would say, yes, consider getting another IUD. Then you've got another 8 to 10 years of progestin, and should you need estrogen, then that's, you've got the progestin being delivered locally, which I think is a really nice approach to menopause. And I think it may minimize the progestin exposure, which is a contributor to some of the risks in terms of breast cancer specifically. So a little bit less progestin exposure systemically can be beneficial. So hopefully that gets to both of those questions there.
Fantastic. Thank you, Dr. Ward. Any other additions, any other comments related to this question?
So I'm going to kind of use that to segue to the next question, if that's okay. So Dr. Ward mentioned, and this is actually, one of the things that's the most challenging is when someone's on contraception. When do you know when they're actually in menopause? And I think, use of FSH is appropriate in those situations. When it's, we can use that as a guide to be able to stop a therapy, which is always a positive. I think one of the things that has gotten really popular lately is I need to have my hormones tested. And actually, there is not a recommendation from most of the major guidelines to be checking hormones in all women. The discussion, the conversation, the assessment of the patient really provides the information that both the patient and the provider needs. And the labs don't necessarily provide that same information. So in terms of testing, there's specific situations, particularly when someone is on contraception. And just let me add that women in the age group of like 45 to 50 something have some very high rates of unintended pregnancy. And I can raise my hand on that. Like, I don't want to be pregnant at age 50. So having that contraception is really important. But in general, lab testing is not a standard of care. And I don't know, Dr. Ward, if you have other thoughts on that.
No, I absolutely agree. And I think, unfortunately, there are a lot of people making money doing lab testing. Sorry, the light's going to go out in my room here. And so that started to drive the conversation. So I have a lot of patients who come to see me, and they're wanting their hormones just checked, kind of out of curiosity, and I explain why we don't do that, and I think they feel maybe let down a little bit. So that's been a difficult thing to navigate in my work of trying, but this other provider did it, and it cost me $3,000, and it was really valuable, and I'm like, what was that?
Well, and those of you, if you watch like 60 Minutes or any news show, you will see that there is now a home testing kit to assess the stage of menopause. And home testing kits, that's actually a topic I used to teach, and it's a favorite of mine. And you always ask the question, what am I going to do differently with this information? And I think that's true for any lab test you get. What am I going to do with this information when I receive the results? And with a home testing kit for menopause, I'm not sure what would be done differently, because just because you're in menopause does not mean that you need to take hormones.
Right, thank you. It's important to put that in the context of what people are hearing, and which is always changing as well. I'd like to turn to another question in Q&A, which is about how we can support members of our family who are experiencing perimenopause and menopause. So, Jamuna, do you have some thoughts on how can a spouse support their spouse who might be experiencing these symptoms and going through perimenopause, and also other family members as well?
Yes, that's so funny. I actually get this question a lot because sometimes this can be a very difficult conversation. I am an advocate of talking about it. We need to normalize this. We need to normalize these symptoms and this transition as much as we can. I actually reflect a lot on like our ancestors, like the generations of women before us that maybe have like suffered in silence, and not knowing that a lot of these symptoms are very common. And so I do think it's very important to talk to our family members. I love the resources that were given, that were given previously that are found in the chat, but just having those conversations with family members, showing them the facts, and then just and asking what specifically they can do to support you through this transitional time. But yeah, absolutely, just providing them the facts that were presented here today.
Along those lines, I mean, that communication piece is so important, right?
Yes.
How do we, but it can be hard for some people to communicate what they're experiencing, how they're feeling, what kind of support they need. Any guidance on that communication aspect and getting and helping people feel more comfortable talking about what they're experiencing?
Yeah, I mean, if we're talking about like having these conversations with family, and you don't feel comfortable actually just having that conversation, I would actually give them these fact sheets, give them the actual literature, have them read it, and then have that kind of spark the conversation. And then also, again, I'll go back to therapy, being able to like, find a good therapist that you really connect with, and just so you're getting support from all different ways.
And are the links that we provided in the chat, do some of those provide information on how to connect with a therapist?
Think so, yes.
Okay, Karen, I didn't, yeah, I'm not quite sure.
The one that is from the government has a huge other list of other connections that's been vetted, and so really talks holistically about the treatment of menopause.
Excellent, great, fantastic. Okay, then let's return back to our couple of questions that we still have in our Q&A from our audience today. So Karen, you talked about hot flashes as the main potential reason to start hormone therapy, but could there also be indications from other combination of symptoms that could be a reason to start, like independent or outside of the hot flashes specifically?
That's a great question, and I think this is definitely something that is talked about in the lay press. So typically, if someone has symptoms of anxiety and depression, or not feeling themselves, or low energy without hot flashes, that might be an indication that there's other medications that have more information and evidence about its use in treatment. Really using estrogen as a antidepressant or anti-anxiety agent is not traditionally done, although it's definitely highly touted in a variety of books out there. But really, there's so many other agents that may be effective and non-pharmacologic, as Jamuna is talking about, connecting with a therapist or counselor, those kind of things. So Dr. Ward, I don't know if you have other thoughts on that, but typically isolated mental health issues without other menopausal symptoms, I would say that.
I agree. I would like to move on to the next question. We can come back to this one if we feel like we talked about, where I would like to talk about testosterone therapy. Did you want to read that question for people that maybe can't see it?
Perfect, Dr. Ward. Yes,
so
great.
important.
How do you counsel about patients who feel very strongly about testosterone therapy? From what I understand, NAMS is fully incorporated into their guidelines, and I don't think ACOG recommends it either, but patients are very interested in it.
Yes, so this has been a very popular thing recently, and that's why I did want to address it. So the question is correct. NAMS has not incorporated it into their guideline. They do have a limited guideline in using it in small amounts to help people who are having issues with libido. And so they do have a guideline for careful use of a small amount of testosterone for libido, in that we don't really have anything else to help women with libido. So if you're seeing a NAMS certified provider, then they're going to be familiar with that guideline coming out of NAMS for judicious use. The testosterone therapy that I'm seeing used a lot in our clinic, though, is I think is really being misused. So people are getting super physiologic doses of testosterone through pellets or injections. And it's not clear to me exactly what people are trying to accomplish with that, if they're hoping to sort of transition or partially transition. Testosterone is a performance enhancing medication. It does build some muscle mass. It creates some mood changes. And, if those are the things women are trying to achieve, then, it would need to look at that. There's some real risks with being on those kind of super physiologic levels of testosterone. So women who have, are starting to get into, there's not a testosterone deficient state in women. So let's start with that. Most women who are ovulating regularly, they make very small amounts of testosterone just at mid-cycle. And women who have high levels of testosterone usually have a whole constellation of medical symptoms that are causing them some other problems. And those women are at risk for high cholesterol, visceral fat deposition, and upper body fat deposition that increases their risk for heart disease. They are at risk for male pattern hair loss and hirsutism, or male pattern hair growth. As you know, as well as changes in the voice and changes in the clitoris. And then the other thing about high testosterone is it's eventually converted to estrogen and puts people at risk for endometrial cancer, and also maybe for breast cancer, and also for blood clots. So using testosterone in the practices that I'm seeing around town, I think, you know, gets presented as you'll gain muscle, you'll have more energy, you'll lose weight, you'll also have this, you know, this amazing libido, but the risks aren't really adequately presented. And I'm seeing a lot of people in my practice, and in fact, I've had 3 people recently with endometrial cancer who all turned out to have been on testosterone. So there are issues with the delivery. The pellets are not FDA approved. They're not being made anywhere in the United States. How they degrade and sort of get absorbed is really variable. Some people absorb enormous doses that could be quite dangerous. There are just a lot of risks with that delivery. So I think, you know, if you're interested in testosterone for libido, please see a NAM certified provider. We do have a pathway to provide that. So as a NAMS provider, I'm going to spend a lot of time talking to people about their relationship and what other things are contributing to their libido before I just jump to that treatment. But the people who are supplying super physiologic doses, I think are, it's really just the Wild West out there. And I have to kind of say, let the buyer beware. This is not safe. Karen, you might want to add?
The FDA has reviewed testosterone for women, I think 3 times, and has deemed it to not be safe enough to approve. So I think that says something.
Absolutely, it certainly does. Well, we are at 10 o'clock, and as you can see, we have a lot more we could and we wish we would like to discuss. So I have a feeling we will revisit this topic and continue this discussion as part of a future WIMS webinar. So more information about that in the future. So to wrap things up today, just one moment, and we understand that people will have to hop off now. But with the MEDiversity Week theme of care for all ages and working to combat anti-ageism in healthcare in mind, what is your final piece of advice or knowledge that you would like, each of you would like to impart on our audience today? So maybe we can, Jamuna, start with you. That'd be fantastic.
I would say just be wary of what you find on the internet. I mean, there's so many blogs and Facebook, and I mean, there's just so much misinformation out there that anyone can go online and tout, you know, that they're an expert in this. I would just say be very cautious of the information. And my first thing would be just to say, go to your provider. Let's just start with that, and let's look at recent research focused interventions rather than just kind of like, you know, like was mentioned before, it is a Wild West out there.
Thank you.
And I think my advice to every single one of my patients, friends and family alike, is the things that really make your life longer, healthier, happier, more meaningful are to get regular exercise outdoors with good friends. So make some friends and go outside and exercise with them.
Excellent recipe.
And, you know, even though I'm a drug dealer, I completely agree with Dr. Ward that the more we know about things, the more that healthy living and making choices that support you as a person are really important. And I think the other thing is speak up to your provider. And if you feel like you're not being heard, find another provider. And I think there's some resources to do that on some of the resources I've provided.
Well, I really want to thank our 3 panelists today for this amazing conversation that we've had, and to our audience today as well. So, as I mentioned, we have a lot more to talk about. We will have a part 2. Stay tuned for that. Another announcement is that WIMS is hosting a presentation with Dr. Arthur Brooks on November 8th. He will be talking about the secrets of self-management. There is a registration link emails out there that's been distributed. Please look for that and please join us for that. That will be in person. Thank you all for another great MEDiversity week. If you'd like to stay informed about future MEDiversity weeks or watch recordings of past events, please visit diversity.utah.edu/MEDiversity. Thanks, everyone. Have a fantastic rest of your week, and we hope to see you all soon.